All right, let's get started and finish up today so you guys can try to enjoy yourself tomorrow at least. It's a joke. Peripheral vascular disease. I'll be on call, first call tomorrow, so if anybody needs to get, or second call, you guys hold me at the hospital. All right, peripheral vascular disease is something that is significantly diminished in the last 10 or 15 years, mostly because of the change in the way people don't smoke as much in this country. Peripheral vascular disease is still a very, very big problem overseas, especially in Europe. But in the United States, the actual incidence is actually going down significantly. Some of the things that you will see is that we've actually have gone away from most of what I'm going to talk about, which is the majority of the disease, which is the induced by atherosclerosis, but instead into talking a little bit about some of the rare syndromes, which is now becoming the more prominent ones in this country because there's just not much of the atherosclerotic process in the smoke-induced ones. Things like the inflammatory vasculitides, such as Takayasu's, thromboangiitis obliterans, called Berger's disease. If you stay in Florida, you'll see it a lot, and I'll explain why. Wegener's granulomatosis, also called lymphomatoid rheumatica, polyarteritis nodosa, and henoch-Schönlein purpura, are all forms of vasculitides. What vasculitides basically are inflammatory processes that attack the blood vessels. As a consequence, begin to eat at the intimal layer and go outwards. Okay, and as a consequence of the destruction of the intimal layer, it increases the thrombotic events occurring, and you get increased levels of clot formation, and you actually will lose the pulses beyond that. Now, there's the inflammatory processes are named by the person who basically identified them. It's really be more fair to call these either conducting artery arteritises or into the resistive arteriitises is what I think you should think of. The conducting ones are the ones that are affecting the aorta and things like the common carotid arteries, subclavian and the aortic arch, and that's Takayasu's. Takayasu's is more of a chronic inflammation of the aorta. Unfortunately, it affects women between the ages of their peak, between the ages of 20 to 50, and usually it affects Asian and Mexican descent. So it's one of those diseases where people come in with strokes. So if you have a 24-year-old woman that comes in with a stroke, don't blow it off. It actually could be Takayasu syndrome, okay, or Moyamoya syndrome. The signs and symptoms is the person usually will develop decreasing perfusion to the brain, so the person will get vertigo, visual disturbance, syncope, seizures, strokes, and they get shortened and stenosed carotid arteries, which you'll hear bruise on the actual hidden with the stethoscope. Cardiovascular, there's a good chance that you'll get multiple occlusions of peripheral arteries. You get sometimes coronary artery disease, cardiac valve dysfunction, and a lot of times these people sometimes will develop left ventricular failure. Pulmonary-wise, can also affect the lungs, including the pulmonary arteries. As a consequence, causes pulmonary hypertension, VQ mismatch. It can also affect major renal artery vessels, which causes renal artery stenosis, renal dysfunction, and renal hypertension. And it also will start affecting blood flow to the vertebral columns, causing ankylosing spondylitis, and also to the joints, causing rheumatoid arthritis, where you get destruction of the actual cartilaginous structures. What happens in this disease process is you don't get enough blood supply anymore to the cartilage. The cartilage dies, okay? And when it dies, it begins to release inflammatory mediators, which then causes the bones to fuse. So if you ever take care of somebody with ankylosing spondylitis, their back is literally fused. They can't move. They're very difficult to intubate, okay? The good thing about ankylosing spondylitis is most people fuse in what? Fuse in the sniffing position. So in that sense, it's kind of good. The only problem with them is when you take the pillow off, their head will be off the bed while they're asleep. And it's a good way to break their neck. So you always got to make sure you support their head properly so you don't injure them. Okay, including the lateral position. You got to make sure the person's properly padded. It's not like a normal joint anymore. It's ankylosed. That's what ankylosing means. It means it's joining together. What it actually looks like is if you look at bamboo, you know how bamboo looks like? You got the two yellow segments, and in between you got the dark band that holds the segments together. That's what their back looks like, and it fuses together just like a bamboo pole. Treatment is high-dose steroids and anticoagulation therapy to prevent the strokes and other things to happen. Now, this is thromboangiitis obliterans. This is a disease of small arteries, so this is resistive arterioles that get affected. Thromboangiitis obliterans is a very sad disease because it's completely reversible by stopping smoking. It's only seen in men, so it's thought to be, well, it's mostly seen in men. It's thought to be an X-linked disease because men only have one X or more prevalent to getting this disease because there's a lack of the enzyme available. But in this case, smoking basically shuts down that enzyme, and the person will then get an inflammatory process of the arteries, and they'll actually get what's called dry gangrene. Okay, I've seen this. Rather impressive. I was my first year as an intern. Actually, I was a fourth-year medical student when I first saw this. It's called also Berger's disease. He was on a veteran. He had, at that point, they had amputated all his fingers and his upper body and his upper extremity, and they had began to amputate the lower digits. By the time I left 5 years later, he was down to using his forearms and had VKAs on both legs, and they had cut his arms at the level of the elbow. And it was rather impressive the guy was still smoking when I left. So I don't think he's ever going to stop until he died. So I have not caught up with him and found out what happened to him, but I can tell you most likely not good. 5 years he went to that, and he was permanently housed in the VA center. Cold and trauma exacerbations can also make this disease worse. So what do? They're told by all their physicians to go south, son. Go south. So they come to Florida. So we have a lot of people with Berger's disease in Florida. We also have a lot of people with Berger's disease in Arizona. So two places where people are told to go to. Usually Arizona has a high incidence of TB because they're told to go to dry air. Okay. So I'm sure people in Arizona are glad to hear that. But here in Florida, we get the Berger's disease in high amounts. And so we also get a lot of people with Raynaud's phenomena. Okay? What you do get signs and symptoms, you get a migratory thrombophlebitis is usually the first sign, and you get intermittent claudication. So these people usually present with back of the leg pain like this lady's showing here. And then eventually, if you don't stop smoking, it starts losing your digits. Treatment is very simple. Stop smoking. So hard. Just do it. Okay? And unfortunately, you're one of the 1%ers in life that you can't smoke if you're one of these people. Okay? 98% of people can smoke and not have immediate problems. This is the 1% club where you have immediate problems. Within a year or 2 years of being on smoking, you start getting claudication. Within 3 years of smoking, you start getting gangrene, or you start losing your digits. And within 5 years, you'll start losing more than that. Okay, so that's something you want to stick with. I remember one lady, I'll never forget, she was the upper 1%. Okay, she'd been smoking for 87 years, 3 packs a day. And she looked at me. I was a young internal medicine doctor at that time. She said to me, she says, "Well, doctor, should I stop smoking?" And I said, "Ma'am," says, "every single doctor that told you to stop smoking is already dead that took care of you. So I think you're okay. You're the 1% that actually has a high levels of alpha-1 antitrypsin levels, that her lungs are absolutely normal. When we did a chest x-ray, her lungs are better than mine. So some people have just the genetics that they can sustain any kind of thing and not have a problem. So in that case, what do? Leave them alone. Keep going. So she kept smoking. She had her fun for another few years. So avoid trauma in these people. Avoid cold. So that's why they stay here in this area. Not so much the trauma, but avoid the cold. Management, positioning is critical. You cannot bounce them around. You've got to maintain the temperature very tightly. Do not put an A-line in this patient. This is what you're asking for. In Berger's disease, you cannot, or thromboangiitis obliterans, do not put an A-line in them. They have a very high incidence of thrombosis, and they will basically occlude their artery. Now, the artery that we use for the hand is what? Where do we put their A-line in? The radial A-line. Now, if you go out and talk to 90% of people in practice, I don't know why they forget this, but if you ask 90% of people out there that are doing anesthesia, which is the dominant artery of the hand, they'll say what? The radial. Now, would you put anything into the dominant artery? So the ulnar artery is the dominant artery of the hand. Okay? So do not write that down anywhere. Okay? Do not write down that the dominant artery is radial. Okay? Now, that's why it's contraindicated to put in a ulnar artery A-line. We never put it in, period. Okay? The other place you don't want to do, and you're not really allowed to do while you're here, is to do a brachial artery A-line. If somebody else wants to do that, that's on their ticket, not on you while you're here. Okay? And I would never recommend you do it. I saw one person do that to a normal individual, and unfortunately that person was an artist, and they chopped his arm off, his good arm. Okay, he lost it below the wrist, okay, for an A-line they had put in for trauma, which they didn't need to do it. They just did it because it was more expeditious. They could have done a radial or femoral, would have been fine. Okay, so don't put a brachial artery A-line either. It's not appropriate. Can you get away with it? Yeah, you can get away with anything in life. It's you're playing craps on somebody else's life. Okay? So if you put an A-line in, what's the chance of you occluding the radial artery when you take that A-line out? 100%. Do you realize that? Everybody that you put an A-line in from now on in your career, almost 90, the rule number is 92%. 92% of them will occlude a radial artery 100% when you pull out the catheter. But does it last forever? And the answer is no. It lasts for 3 days. Can you go without a blood supply to your hand for 3 days if you don't have good collateral flow? And the answer is no. Okay? Versus in the brachial artery up here, if you knock that out, you occlude both arteries as a consequence, and that's it. You're in big trouble. You will lose a hand. Okay? No. So in this patient specifically, don't give an A-line. Increase your FiO2, at least 50% FiO2 minimum. General anesthetic-wise is considered safe, so is regional. Just avoid epinephrine. The biggest problem with general or regional is don't let them get cold on you. That's a critical part of it. And maintaining perfusion pressure is pretty important in these people as well. But when I put these people to sleep, I've never had any problems with any of the meds or anything like that. Never been an issue. Just rather the pulse oximeter is really kind of a pain because you can't pick up the digits sometimes with pulse oximeters. You have to use the ear one or you use the one on the tongue. Okay? The tongue one actually works very well all the time because it has blood flow to your head. So if you can't get one on the finger or on the ear, put it on the tongue. Let's see. Okay. Just avoid epinephrine. They're hypersensitive to epinephrine. Wegener's is a nasty disease. Wegener's is a granulomatous formation. Okay. What the granulomas do is they actually are caseating, which means that the reason it's called caseating, casein comes from the word cheese. Okay, when you actually open up one of these granulomas, it looks like cheese, like white cheese. Okay, and actually it's got layers of it. What it does is, unfortunately, it causes the extreme inflammatory process around these granulomas. So these things are usually very vascular. Okay, so if you have a granuloma in your nose or in your airway, and you hit that with with an endotracheal tube or with a laryngoscope, you're going to find out how vascular they are. You will have a massive hemoptysis at that point. Okay, so you got to be very, very careful not to hit these things if at all possible. Okay? If it goes in the lung, which is another very strong possibility, which is part of the process, if it erodes into the pulmonary artery, it can be lethal. Okay, seen that happen. Not pretty. So these are called necrotizing granulomas. They also can attack the kidneys, the heart. The kidneys are the most common cause of death from Wegener's is end-stage renal disease. Signs and symptoms is that it can erode into the sinuses, so you can get a sinusitis. It can erode into your maxillary sinuses and erode into your hard palate. I've actually seen where we actually intubated the individual and the palate was actually partially gone. Didn't cause us any problems, but you definitely wouldn't want to put an NG tube or anything like that through that guy there because you'd cause massive hemorrhaging. You can also get into trouble because sometimes it involves the larynx. So if a person comes in and is not talking properly, make sure you get a CAT scan of the neck. Make sure that the granuloma is not involving the larynx. I've actually seen where we actually had to do a trach on the individual before we started the case under local because the granuloma was involving the epiglottis. Okay, and it was completely involving it. So you don't want to do that. If you touch that sucker, what would be a really bad blade to use if it's involving the epiglottis and the vallecula. The Mac blade would be useless. You can't use it at all. The straight blade, you can avoid it possibly, but you're going to have to still lift the structure, so there's a good chance you're going to bleed. So not a good thing either way. So the choice we made was awake intubation with tracheostomy, which is fine. And he needed it anyway, so he could breathe afterwards. You can also have the involvement in the trachea itself, which is a nightmare. Usually these people become very symptomatic at that point. They will get short of breath. And when you put positive pressure ventilation, that's okay. It's rather when they're trying to take in big, deep breaths spontaneously where the trachea will actually occlude. So the pulmonary vessels can lead to VQ mismatch, pneumonias, and hemoptysis develop, especially the roads into the pulmonary artery. Signs and symptoms, you get infarction in the tips of the digits like this. You can almost get what's called a target lesion. You can see it looks black in the middle, that's a necrosis, and around it is a purple spot all the way around it. I've seen several of these in my career that are pretty pathognomonic with Wegener's. You got to be careful because sometimes the coke addicts, not so much the coke, but not the cocaine, but the crack addicts, they'll get something that looks similar to this. And the reason that is because the way crack is used, they usually put it into a can, usually like a Coke can, and they use that as a melting to vaporize it, and they put a hole on the top to be able to take the vapor from outside to come in, and then they as they wanted to breathe in, they glued it with their finger. But when they glue it with their finger, they burn themselves, and they get a circular burn that looks similar to this, very different than this. This actually will cause just a circular black burn usually on this finger. Okay, sometimes you pick up and you go like, oh, it's Wegener's, and it's not. Okay. I found out that's one of the reasons I found out. So I said, this doesn't make sense. It looks like Wegener's, and it's not. So I kept finding out, and I found out, and then the guy was willing to help me by teaching me how they actually did crack. I was in the customer. Bad news. In Tampa, they went from never seeing crack. By the time I finished my training, almost 50% of the mothers that were coming in were crack positive. It was horrible. It was literally became like a plague in Tampa. And it went from being a small town where nothing ever happened to being one of the highest trauma centers in the state. It was amazing how bad things were for a while. Things got better now in Tampa, but it was bad there for a while. The kidneys can actually get complete destruction of the renal glomeruli by these granulomas. They get hematuria, azotemia, and a lot of them will actually be the most common cause of death is progressive renal failure from this disease. Treatment is high-dose cyclophosphamide, which is basically, we know it's an inflammatory mediated reaction, so we shut it down, which unfortunately cyclophosphamide can cause leukopenia, which increases the risk for developing of secondary infections. You're also suppressing the bone marrow, so you're getting hemolytic anemia development. And the big concern is that it also affects plasma cholinesterase development. So these people have variable response to succinylcholine. Sometimes they're hyper-responsive, sometimes they're not. Okay? And the other, of course, is corticosteroids to suppress their immune system. The next process is temporal arteritis. Temporal arteritis, if left alone, will cause unilateral blindness and sometimes bilateral blindness. It's an acute occlusive arteritis of the ophthalmic artery. We can actually pick it up on the temporal artery right up here. That's why we actually do the biopsy on the temporal artery. Treatment is high-dose steroids, but usually these people are older, so you don't want to give people high-dose steroids unless you have definitive diagnosis. So what's done for that is we do a temporal artery biopsy, usually done under local anesthetic and sedation, heavy sedation if that is. You always make sure that the surgeon's working where I said, right here in the temporal area. Okay? Had a surgeon was working one time because the actual OR nurses prepped the field. The surgeon must have been a little tired, and they prepped it and they put the blue drapes around it and they made it look like it was here. And the two people that were in the room didn't really notice it very much. And when I came in between after they started cases with the surgeon, I looked over the top and I'm going like, So you might want to check where you're at. You know, surgeon stopped, looked at it, said, uh-oh, and he just closed it up, went up. Small snick incision, not a big deal, but if he kept going where he was going, he could have gotten the parotid gland or gotten into the facial nerve. Okay, so this is called wrong site surgery. Okay, it happens. So you have to be aware where the surgeon's working. Please don't think just because the other end you think that they're smarter than you. They're not. They're human beings just like you. They're going to screw up just as fast as you can. Okay? So always make sure that happens. I had one of the best nurses that I know, and she's really good at putting IVs in the other day. I came over to her and told her, hey, you know, you put an IV on the same side as her shoulder. Shoulder. It's really not a good idea. So it's the first time she'd done it in 25 years. She actually put the IV in the wrong side. So things like that, even night things like that can happen. So if people that are really reliable, it happens on a bad day, anything can happen. So be aware, always look at what the surgeon's doing, make sure that he's where he should be and not doing something he shouldn't be. So it may make a difference. The patient did fine. The patient got told afterwards that it had a small little cut, went above it, no big deal. The patient did fine. Everything went fine. So things like that happen. And nowadays, that was 15 years ago. Nowadays, we'd have to report it, call it Code 15. It would be a nightmare. That person would be up for severe restrictions, and you'd lose your license and all this stuff. It's just gone to the point that it's punitive. And, you know, it's just, to my way of looking at it, it's kind of ridiculous. People are going to make mistakes, but we're not allowed to make any mistakes, apparently. Polyarteritis nodosa is the next disease. This one's a little bit difficult to diagnose because it's a multisystem disease. It's acute inflammation of the small arteries. And your kidney, because it has full of small little arteries, is involved in this very often. So you get proteinuria and azotemia, but you don't necessarily get hematuria. You induce hypertension because of the involvement of the glomeruli. There's an increased incidence of MIs, and treatment of this is steroids. How you actually diagnose it is that you got to understand that it's attacking all the small vessels, so you can increase the risk of stroke, heart attacks, bowel infarcts. This is how we actually picked it up. The patient came in with multiple bowel infarcts, hypertension, and then they came in with this, and this is what they're going to debride in the operating room. Not necessary. This is actually the typical pathognomonic of polyarteritis nodosa, which is these kind of little inflammatory infiltrates on the actual surface of the skin. You don't need to debride these, just leave these alone, they go away once you treat it with steroids. So we actually made the diagnosis in pre-op and the patient went back to the floor. Yay, one less case. So, saved the guy from getting having to get a graft put on his leg, so kind of a good thing. And they don't heal very well, by the way, when you do fix that area, so the graft in itself wouldn't have been good. The reason I end up learning a lot about this stuff is because our centers would all get this weird stuff coming in, so we'd see these kind of things, and you have to really pick up on it, so you wouldn't have to operate on people like this. Henoch-Schönlein purpura, I've only seen it once. In this case, it was a child, and the kid almost died on us. It usually presents as in the kids, they usually have inflammation that attacks not only their skin, which is what you normally see, but they complain of severe joint pain. It begins to also attack the kidneys and the GI tract, and you can get microhemorrhaging, and that's when they usually can present with septic shock, okay? Because they get almost like GI infarcts. What happens with the skin is it looks initially like this. This is typical. It usually happens in the lower extremities for some reason. I didn't see it in the arms too much in this kid. You saw it in the lower extremities, and then you saw it do this. It confluences, it comes together, and it becomes a giant red patch, okay? And these are microhemorrhages that are occurring at the skin level. Okay, this is happening inside the organs of this child. Okay, so this is not something that's good. It's happening inside the GI tract, it's happening in the kidneys. So this is one of those things that if you don't give the person high-dose steroids right away, it can progress and cause death. The way it's actually diagnosed is usually they get punch biopsies of the skin, which can be done with a local anesthetic and get it into the lab and get looked at. Raynaud's disease is going to see something very common here in Florida because, again, these people are induced by cold temperature. So a lot of these people travel, especially to South Florida, in Miami and in Naples here in Fort Myers, because we're the warmest part of the state. So if you were up in the Panhandle, these people don't live up there. They come down all the way down here. So there's a huge amount of people with Raynaud's disease in Miami, believe it or not. I have one of my friends who works there. He tells me about it all the time. Says we got a huge amount of lupus and Raynaud's and scleroderma, and I've seen a lot of scleroderma here as well. because the Raynaud's is associated with this as well. The female incidence is pretty high with this. It's almost 80%. Raynaud's basically is an abnormal sympathetic response in which you get is intense vasoconstriction. That's not the uncomfortable portion. You'd think that. When you look at the blood vessel, look at the skin right now, it's completely white. This is not paint. This is what the skin actually looks like. Okay? It completely turns white like this. And this is a very severe Raynaud's. Okay, I got to give them that much. But you do get it that severe, especially in the cold temperature climates. And that's not what the uncomfortable part. In that part, the person usually feels numb. They don't really have a lot of pain. It's when they get the reperfusion that it hurts like crazy. When they get the reperfusion, it has terrible throbbing pain. They can actually measure their pulse rate by their throbbing pain levels. Okay, they can actually, every time the heart pulsates, they can feel it in their digits. And it's very impressive. And you can hear them, they cry out. It's not a continuous cry. It's like you can pick up, and you walk in a room that has somebody with this, and they're having that spasm period, they'll be screaming at different levels of height, consistent with their heart rate. It's pretty impressive. You have to sort of take my word for that until you actually hear somebody do that. I can't repeat it. I don't know how to do it. You do get, eventually, this throbbing pain goes, if it gets too bad, it will actually necrose and you lose the digits if you're not careful. Treatment avoidance precipitating factors, usually stress will induce these people a lot. So they're usually told to don't do a lot of stressful work. I'm not sure if that's really necessarily the truth. It's anything that causes them to be stressed. It could be just normal activity with their family. That can induce stress too. But the precipitating factors that are really major is cold. Cold is really a big thing. And smoking also is bad. So if you have a lot of times these women don't smoke, but their husband smokes or their significant other smokes, and then they get worsening symptoms. So they have to stay away from anybody who smokes. Secondary effects of smoking are really detrimental to these people. Even a whiff of it from their clothes can cause problems. So I've had people actually tell their husband to take all their clothes off before they walk in the house, so make sure they don't have the smell of smoking on them because it bothers them so much. The actual nicotine that comes off them is pretty bad. If you've ever been in a smoker's house, if you don't believe me, pull the screen, pull open the curtains, and look at the top of the curtains. And the curtains are no longer white. Usually the inner lining of the curtain is white. If you look at a smoker's house, it's actually yellow or dark yellow. It's actually from the nicotine that's coming off the smoke. It actually absorbs into the sheets. And that actually then goes out into the environment and causes problems for these individuals. They have a tremendous sensitivity to those agents. Some of the treatments include sympathectomy, which we're doing some of them as well here. And I'm doing a thoracotomy. We actually will do a sympathectomy and actually cut the nerves that go out, and actually works pretty well at stopping this problem from recurring. Management, positioning is very similar to like Berger's disease. Temperature is critical. A-line is really kind of questionable. This is more of a smaller vessel disease than Berger's disease. So some people do use A-lines and they have in the past. I would try to avoid them as much as possible, and if I did have to put one in, I'd put one in a major blood vessel like a femoral artery. I'd stay away from the radial. But some people say it's okay, so I don't know. There hasn't been really a lot of bad reported cases of A-line problems with these people. Regional is really good because it keeps perfusion going, and that way the person's awake talking to you. And so I use a lot of it, and just avoid epinephrine. Don't give them epi. And we're talking about moya. It's a little bit more rare. It's a neurovascular problem. It causes narrowing of the internal carotid arteries. Children are more affected than adults, so these are the kids that develop TIAs. Adults themselves have increased risk of intracerebral hemorrhage, and about 14% have associated aneurysms with them. Medical therapy actually includes aspirin and cerebral vasodilators, such as calcium channel blockers, and surgical intervention sometimes is needed to do a bypass to keep these people's blood flowing to the brain. All right, so let's go on to the next one, which is acute arterial occlusive disease. We went from vascular disease to the acute arterial occlusive disease. Okay, by far the most common of these is emboli. Emboli usually originate in the heart, instead, in this case, left atrium. Okay, specifically in the left atrium, in the left atrial appendage. That's where we look at it under TEE. Okay, that's the area with the lowest blood flow to the heart and the left side. And you also can get this if you have akinetic areas of the heart. You can actually form thrombi on the akinetic portions where the heart's not pumping. So post-MI may also increase the risk of developing these. The patient that develops atrial fibrillation also has an increased risk. Atrial flutter still is lower because there's still some movement. In atrial fib, there's no real movement of the atrium, so the risk goes up. Prosthetic heart valves, if the person has been doing drugs IV, which I saw many times in Tampa, people were injecting themselves with heroin a lot, and heroin then was being cut with baby powder. What else they were cutting them with? They used there for a while. What was it? It's acid. Can't remember the name of it. It's basically a cleaning solution. Was it? What was it? Comet, yeah. They were using Comet, which is a form of acid, and they were injecting it into their bloodstream. And it was burning out their heart and heart valves, and they would get endocarditis right away with it. It's pretty nasty stuff. So much for that way. The bad thing about doing that is you kill the person who's using. So it doesn't really make you a lot of money in the long term. So you want to keep your people in good health while you're doing this stuff. Actually, one of the best persons I ever learned putting essential lines in was from a guy that worked in Tampa as a what's it called? It's not a liner. What's the name of the guy? Call him a shooter, I think is what the name of it was. But the guy's job all day long was to inject into your vein for you for about $15 as a central line. He'd line you up and inject you with your heroin or whatever else because you had no other vein left. So he actually made a living doing it. He would do 15 to 20 people a day at about 15 to 25 bucks a piece. So he was actually telling me, Doc, you're a little bit off. You got to come a little bit more medial. What? He says, how do you know how to do this stuff? Says, I do it all the time, man. I do it every day. He says, how many do you do a day? It's like 25 a day, $25 a day, $25 each one. It's like, wow. I said, what's your complication rate? It's pretty small. The only problem is when I do get a complication, I get pneumothorax, they want you trying to shoot me. So there's not too many of those in town, I suspect. They got it really good at what they're doing. But things are kind of crazy. You can also get left atrial myxomas to form, which is our tumors that are inside the left atrium. Signs and symptoms that you get with this disease process is you get acute demarcation of color changes. So you get blood supply, it's a nice color, and then below it you see it turns white. And the person usually also has severe pain right below that demarcation point because of ischemia. The skin feels cool. You get no distal arterial pulses. And a lot of times when you feel it, it's your own pulse. It's faking you out, so you usually use Doppler. Don't trust your own fingers because a lot of times at that point you're pretty desperate to feel something. So you can feel your own rebounding pulse off your skin. So always when you have somebody like this, check your Doppler. Doppler is much more accurate. If people have severe ischemic pain, it's way out of the norm. They're actually not faking it. Paresthesias are pretty obvious. If you wait too long, the nerve actually dies and is permanent. So you don't want to wait too long. The muscle will actually necrose and develop compartment syndrome. And that's why we have to, sometimes after we do a revascularization, we'll have to do an sclerotomy, which we actually cut the skin open and let the edema decompress. And then you can also get rhabdo. Rhabdo is pretty nasty. You get end-stage renal failure, and then you get into a worse situation. Treatment is, thank God, as we've gone into radiology. Radiology has really made a huge difference for us. It used to be surgical. It was a nightmare. We'd call it bypass, chop, chop, chop. Usually we bypass twice, and then we start chopping the leg off. The good thing about radiology, putting stents in and doing thrombolytic therapy, is that the intima stays intact. There's less chance of you having to do amputations on these individuals. So for that reason, it's much better to take them to radiology suite and take care of them there. If you look at chronic arterial occlusive disease, thank goodness that's gone down considerably in the last few years because of the changes in smoking habits in this country. Still, we still got a problem with diet, but at least we got one of them beat, which is tobacco, at least mostly. The biggest problem now we're having is obesity, which is also accentuates this atherosclerotic problem. I'm not going to talk about it too much because it's the same thing as acute arterial occlusive disease. It just progresses. Venous thrombus formation is the next part of this topic. And Phlebothrombosis means that the venous thrombus forms with no signs of symptoms and usually doesn't progress. But then you get thrombophlebitis, which is more severe, which is you get venous thrombus formation with inflammatory changes. Usually that person has an increased risk for developing DVT and increases the risk of PE, which we just talked about. Predisposing factors for developing the thrombophlebitis is venous stasis, such as surgical procedures, pregnancy, congestive heart failure, patients with MI with low cardiac outputs. If you have varicose veins or drug irritation, like from chemo or from anything else, you increase the risk of having abnormal venous walls. And if you have an alteration in coagulation states, such as in oral contraceptives and carcinoma, you increase your risk as well. The other thing that increases the risk for this formation is orthopedic procedures, especially ones of the hip or knee, which basically immobilize you. Morbid obesity and elderly. Almost every single one of those is what we do every day when we do knee replacements and hips. Everybody who's getting a hip replacement is obese or overweight. The reason that is because most of them, they've worn out their joints. And the other bad thing is once your joints are starting to go out, what do you start doing? You become sedentary. So weight begins to pile on. So these people are a perfect storm for us to take care of for developing a massive PE on us. They don't happen in the operating room, they happen on the floor. What you can do to help it from the standpoint of anesthesia point is regional anesthesia decreases the incidence of DVT formation because you cause actually venodilation and improve circulation to the lower extremities. So this is one of the few things where you can actually tell somebody, well, is one safer than the other? Answer is general anesthesia and regional anesthesia is not any safer. The only thing you can say is that regional anesthesia is has less risk of developing a PE. Doesn't change the anesthetic concerns, but just changes the outcomes possibly. Signs and symptoms, a lot of times these people have throbbing pain, cord-like pain structures. I've only seen cord one time. Edema will be a pretty common sign, but that could be consistent with just a muscle sprain. And sometimes it's associated with a muscle spasm where somebody will tell you that they've actually turned their leg improperly and they just don't feel right. If you ever think about any of this stuff and it doesn't really, if they have a low-grade temperature, like 99.8, get an ultrasound of the legs, okay? Because it's very likelihood it's a DVT. You just don't realize it. You don't know, it's not always easy to pick up. Ultrasound was actually pretty easy to do and actually will show up pretty well. And also the thing that also picks up the DVTs, which is the deep venous thrombosis, which in the pelvis are the ones that we really have to be concerned about, are done by a CAT scan. Okay, venogram, you only get to person do one-time venogram. I think venograms are torturous, and I've seen it done. It's really not fun. You hear the person screaming. That to me is a torturous exam, and the likelihood of you damaging the vein is pretty high. If you're hearing somebody scream, that means they're inducing pain. That means endothelium is getting damaged. So I don't think really a venogram is a good idea. So ultrasonography or CT that really don't cause a problem should be all right. Now, of course, people are going to argue now in the opposite, saying that CAT scans are going to increase the risk of developing cancer because it increases the risk of radiation exposure. Well, then ultrasound is the way to go. So it depends on how we go in the next few years for who's concerned about what. Venograms is still going to cause radiation, so it's still on the bottom of my list of things to do. I never ordered it. I only did one venogram. I saw it done once and never ordered it again. And you know what happened after the venogram? The radiologist says, unclear, recommend a CT. Why the hell did you recommend a CT in the first place? But anyways, prophylaxis. Heparin, what we do here is we give Coumadin on the day of surgery. Do not worry about having to do a spinal on somebody who has Coumadin on the day of surgery or even on the night of surgery. Their PT, PTT will be absolutely normal. Okay? The reason being is it takes a long time for Coumadin to be absorbed into your GI tract. It takes about 24 hours to upload. So you're still totally safe to do a regional anesthetic on them. Now, should you do it the next day? The answer is no. So if the patient took it 2 days early, then you better check your PT, PTT, and INR before you start doing your regional anesthetic. But otherwise, you don't need to. Okay? As long as they've already had normal coags and then they got the Coumadin the night before. If the person was given heparin, guess what? You can't do it. You can't do a regional anesthetic if you're given heparinized. That's immediate. That works very quickly. Compression stockings work not by, most people think that when you put a compression stocking on somebody that it's compressing the muscle and that's what's causing the anticoagulant effects. And the answer is no. You can actually take a compression stocking and put it on somebody's arm and just be as effective as putting that on their legs. So what's being released? The answer is a heparin-like substance is being released every time one of those things is inflated. So it does not really matter if it's on your legs or not. So if you have one broken leg and you can only do the compression on one leg, that's fine. If you have both broken legs, then put it up in the arm. And it'll work just as well. Okay? Most people don't know that. But it's kind of interesting. It's an interesting study that was done a few years ago. Treatment, if you do develop a DVT, is anticoagulation to hopefully break down the clot. If the person's thrown out a PE or they're at high risk group, if they've thrown a PE before, then IVC filter is the name of the game. The IVC filter here that we're showing you here is a green fill filter. Okay, sometimes it's called a bird nest filter, which looks like a wire that's all wrapped up. Okay, the green fill filter is about 99% what's put in now in this country. Okay, because it's the most effective. Okay, the other two companies have sort of gone out of the wayside, and Greenfield is pretty much the only one that's left, which is good because they're the best ones to put in. The good thing about Greenfield cell filters, if you want to take them out, you can. Okay, most of the time. The bad thing about a Greenfield filter is if you put in your central line, if you put in beyond 20 centimeters, you can actually, if you have 30 centimeters and it goes into the inferior vena cava, you can hook up onto one of these. I got called at 3 o'clock in the morning by one of the attendings here, and I said, I can't pull the wire out. And my first question was, how far was the wire put in? He said, well, I'm at 35 centimeters. Okay, so don't pull it out. You've most likely hooked up the IVC filter. And he says, the patient doesn't have an IVC filter. He says, they do, you just don't know it. And he's laughing at me over the phone. He says, nah, it can't be. It can't be an IVC filter. I said, trust me, it is. It's the only thing it could be. Okay, there's nothing else metallic that would hold anything in there that would hold a wire. Okay, and the reason that the person didn't know it was they had it done when they were in ICU, intubated, asleep. So they didn't remember they had an IVC filter. So you always have to have in your back of your mind that every patient that you take care of in Naples has an IVC filter. These are all over 80 years old and they're all trying to die. Okay? Okay, so make sure you only go to 20 centimeters, okay? The funny part is he did find out, did the x-ray of the belly, and sure enough the IVC filter was there and the wire was stuck in it. What happens is we have a J-loop at the end of the wire. The J-loop acts like a giant hook. Looks like a J. That's why it's called a J-loop. Well, that J-loop goes right inside the IVC filter, and if you try to pull it, it just lodges it worse. It doesn't let go. So it's really easy to fix. Call radiology. Radiology comes in. They're so happy to see you at 3 o'clock in the morning. They're really coming in to help you. Okay, they'll call you every single word in the book, which is fine. You sort of absorb it and take it. And then they take a plastic tube, put it over the wire, thread the plastic tube all the way down, okay? And then they just push it onto the J-loop, and all of a sudden the J-loop comes off and comes out, and you're done. No big deal. And then they can finish putting the central line in for you, since they're already there, so they can charge for it. Make up for some of the stupidity. So, but don't pull it. The reported cases of people pulling it was immediate exsanguination, okay, in one of them. The IVC filter was pulled out. It ripped the inferior vena cava in the process. The patient died on the right there and then because they bled out. The second one that was reported was the IVC filter was found inside the right ventricle and killed the patient too. So, not something I would recommend. If you put something in easily and you can't pull it out, stop. Stop. Don't yank. Okay. Where I also happened to me one time was we put in a PA catheter in an open heart patient. When at the end of the procedure, we were always asked to check by pulling on the PA catheter, which we did, and I couldn't move it. I told the surgeon that. The surgeon came up to the top of the bed and says, you just don't know what you're doing, son. I'll teach you how to pull the PA catheter out. I said, really? He said, okay, all right, I'll step back. So she grabbed the PA catheter and yanked it as hard as she could. And all of a sudden, we're looking up. The PA pressures start dropping. I pulled out my PA catheter, which now is completely out of the body, and I said, is this normal, doc? And she looked at me and said, what's that? She says, a piece of chunk of metal, of meat attached to the blue string attached to the PA catheter. She had sewn the PA catheter into the right atrium. So we were exsanguinating inside, so the chest got opened up real fast and got an extra stitch put in. So don't pull out anything, okay? If it's stuck there for a reason. It's usually because something bad's happened. You know the chances of somebody putting a suture through a PA catheter and actually suturing into the heart? Infinitesimally small. That everything happens to me, so what the heck? You know, I'm not making this stuff up. Somebody asked me the other day, says, I'm always bad when I'm on call with you because I know something bad's going to happen. I said, thanks. So actually we had something bad happen last Sunday night. I was working the acute was it? Person came in, massive hemoptysis from a tonsillectomy. The patient was bleeding out from a tonsillectomy 3 days post-op. He decided to go out and eat a hard taco at 12 o'clock at night because Taco Bell was open at 12 o'clock at night. So he came in at 1:30 with acute hemorrhaging because the taco went down and scraped his tonsil arteries, went down. So that was an exciting case. The student intubated, though. She did a good job.